Welcome, Zooassembliers! My name is Zouk Azalishvili and I'm the founder of Zooassembly. Zooassembly is an online podcast for the highest yield basic science and clinical knowledge tested on UAssembly Step 1 and UAssembly Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zooassembly. Now, let's start rolling. Today we will discuss the respiratory pharmacology. And the first topic that we're going to talk about is the antihistamines. Antihistamines are also known as the H1 blockers because these medications block the histamine 1 receptor or the H1 receptor. They also block the other receptors which contribute to other utility and also the side effects, but the main mechanism of these medications is to block the H1 receptors. They are the reversible inhibitors, which means that excessive histamine can actually reverse the effect of the antihistamines. And an important thing to mention here is that antihistamines signify only the H1 blockers. Let me give you a question, guys. Do you remember which medications are considered the H2 blockers? Are you saying cimetidine, ranitidine, famotidine, and nizatidine? If you are totally correct. And the reason I'm reminding you these medications here is to emphasize the fact that H2 blockers are not called antihistamines. Although technically they are antihistamines, we call this name only to the H1 blockers. And the H1 blockers can be either neutral antagonists or they might be the inverse agonists for the H1 receptors. Let's draw the line of difference between the neutral antagonist and the inverse agonist. And for this, let's take a step back and talk very briefly about general pharmacology. As we know, all the receptors in our body can be in active and inactive conformation. And at any point in time, some of the receptors are in the active while some are in the inactive conformation. Let's take an example. Let's say that we have the vascular smooth muscle, a smooth muscle cell, and on the plasma membrane of this cell there are 10 H1 receptors. And just for the sake of example, let's say that 3 out of these 10 H1 receptors are always in the active conformation, meaning they are always working, while the remainder 7 H1 receptors sometimes work but sometimes don't. So it depends on whether they have sufficient stimulus, that is histamine. Those 3 H1 receptors, which are constantly on, create something called baseline activity of the certain receptor, right? And when we say that the drug is the neutral antagonist of a particular receptor, what we mean here is that the drug will block the activation of the receptors which are in the inactive conformation. If we go back to our example, we said that 7 receptors were in the inactive conformation, right? And if these are the H1 receptors, and if we give the neutral antagonists, then those neutral antagonists will block the activation of those 7 H1 receptors, but they will not decrease the activity of those 3 active H1 receptors. Therefore, neutral antagonists do not decrease the baseline activity of the receptor system. This is in contrast to the inverse agonists. Inverse agonists are called so because they act in the opposite manner of the receptor agonists. Inverse agonists block not only those receptors that are originally in the inactive conformation, but they also decrease the activity of those constantly active receptors. Therefore, inverse agonists decrease the baseline activity of the receptor system. And yeah, I know this was not particularly short discussion, but I think it was worth it for us to imagine what the neutral antagonists and the inverse agonists do. Okay, let's get back to the antihistamines. We have 2 generations of antihistamines, first and second. The first generation antihistamines include the drugs like diphenhydramine, chlorpheniramine, dimenhydrinate, doxylamine, hydroxyzine, promethazine. There are many drugs which belong to the first generation H1 blockers. However, the first 4 that we described are particularly high yield. Let me remind you those 4. This was diphenhydramine, chlorpheniramine, doxylamine, and dimenhydrinate. In addition to blocking the H1 receptors, the first generation antihistamines also block the muscarinic receptors and alpha-1 adrenergic receptors. Let's talk about the clinical significance of this pharmacological piece of information. We know that muscarinic receptors are prevalent throughout the body. They are also present in the brain, specifically M1 subtype of the muscarinic receptors, and in the brain, M1 receptors mediate the higher cognitive function. When we administer the first generation antihistamine to the patient, then this drug blocks both histamine and muscarinic 1 receptors, and this will cause sedation and depressed consciousness in the patient. This is actually why the first generation antihistamines are commonly used as a sleep aid, or the sleep pills. At the same time, blockage of the histamine receptors causes weight gain, and this is a serious side effect of any medication that has antihistamine properties. And finally, since the first generation antihistamines block the alpha-1 adrenergic receptors, then they can cause the orthostatic hypotension. Okay, zooassembliers, I have a question for you here. So can you think of the mechanism of why the medications with alpha-1 blocking activity can cause the orthostatic hypotension? I hope you already have an answer. Alpha-1 receptors are present on the vascular smooth muscle, and since they are the GQ-coupled receptors, their activation causes vasoconstriction. So if we give the first generation antihistamine to the patient, then those alpha-1 receptors will be blocked, and there will be insufficient vasoconstriction. So the vessels will not be able to increase their tone, and this will cause orthostatic hypotension and orthostatic presyncope, if not syncope. What I mean here is that if the patient takes the medication with alpha-1 blocking activity, when he or she stands up, specifically if he or she stands up suddenly, then they might have some dizziness and nausea and the sensation of losing consciousness. And this is due to the fact that venous return is not increasing as rapidly as it's supposed to increase because the peripheral veins are dilated. Okay, and definitely antihistamines, both first and second generation, are used for the allergies. Now, can you tell me why we use these medications for the allergies? I hope you're telling me that most of the allergic reactions are mediated by histamine, and antihistamines block histamine. So this is why they are effective in the allergies. Right, let's move on to the second generation antihistamines. Second generation H1 blockers include the drugs like loratadine, desloratadine, fexofenadine, and cetirizine. Second generation antihistamines are far more selective for the H1 receptor compared to the first generation H1 blockers. In other words, they have much less of an activity towards the muscarinic and alpha 1 receptors, and therefore they have much less sedating properties. Another reason for why the second generation antihistamines are far less sedating than the first one is that they have poor penetration into the CNS, in contrast to the first generation antihistamines. And since second generation drugs don't have that much anti-muscarinic and anti-alpha 1 effects, they are not used as a sleep aid or anti-emetic medication or for motion sickness. Oh, yes, I have forgotten to tell you that first generation antihistamines are also used for the motion sickness and also as an anti-emetic, especially in pregnant ladies. Let's also briefly talk about this phenomenon. Motion sickness is when people are hypersensitive to the movement of the transport that they are transported with, right? So, for example, if somebody is on the ship or on the plane, they might get the motion sickness. And motion sickness is characterized by the sense of nausea and the actual vomiting. Here's the thing. In the brain, specifically in the floor of the medulla, we have something called chemoreceptor trigger zone, which contains area postrema. Guys, this is actually a very high yield info from the neuroscience. And area postrema contains many different types of receptors, activation of which induces vomiting. And one of such receptors is the H1 receptor. So if we give first generation antihistamine to the patient with motion sickness, then this drug will cross the blood-brain barrier, block the H1 receptor in the area postrema, and it will prevent vomiting in the patient. This is why we use these drugs for motion sickness and also as an antiemetic in the other situations as well. Okay, so this was discussion about the H1 blockers. Let's move on to dextromethorphan. Dextromethorphan is an antitussive medication. The word antitussive means against cough. So in other words, dextromethorphan is the cough suppressant. The way it suppresses the cough reflex is that dextromethorphan antagonizes the NMDA receptor, which normally is activated by the glutamate. So this is the main mechanism of action for dextromethorphan. But an interesting thing about dextromethorphan is that this drug is the analog of synthetic codeine. Guys, do you remember which class does the drug codeine belong to? Are you saying that the codeine is an opioid? That's perfect. Codeine is an opioid. And if dextromethorphan is the weak analog of an opioid medication, then logically speaking, if the person overdoses on dextromethorphan, then we might get the typical signs and symptoms of the opioid intoxication. These signs and symptoms include things like respiratory depression, meiosis, a decreased level of consciousness, things like these. And if the patient has the symptoms of opioid intoxication after taking excessive dextromethorphan, we can actually give the typical opioid antidote to this patient. Okay, here's one question for you. Do you remember the name of the antidote for acute opioid intoxication? That's right. That's right. It's naloxone. So we can give naloxone to such patient. Another very high yield fact about dextromethorphan is that in addition to blocking the NMDA receptor and activating the mu opioid receptor, it also works as a very weak SSRI. SSRI, let me remind you, is the selective serotonin reuptake inhibitor. The drugs that are usually used in depression, they increase the concentration of serotonin in the synaptic cleft. Now, if we combine two or more serotonergic drugs, this will result in very, very high levels of serotonin in the synaptic cleft and generally in the CNS. And this will consequently result in the serotonin syndrome. Serotonin syndrome is an extremely high yield condition for both step 1 and step 2 CK. We are not going to go into the details about the symptoms of serotonin syndrome here, because that's the topic for the psychiatry and the toxidromes. But what I'm going to tell you is this. Let's remember the general rule of thumb. When the medications have serotonergic effect, then we should avoid combining several of these medications because their combined effect can result in serotonin syndrome. The same is true for dextromethorphan. Let's imagine the case where we have the patient who has the past medical history of MDD, or major depressive disorder, and he is on fluoxetine. And then he just got the acute bronchitis, and it was so severe that he needed the symptomatic therapy, and the physician accidentally prescribed the dextromethorphan. And then the patient comes with the typical signs and symptoms of serotonin syndrome. So the question might ask, what's the most likely underlying pathophysiology of this reaction? Or let's say, which of the following medications was administered to the patient? Something along these lines. Okay, this was discussion about dextromethorphan. Let's move on to the pseudoephedrine and phenlephrine. Okay, both of these drugs, pseudoephedrine and phenlephrine, activate alpha-1 receptors. Guys, can you tell me from our discussion in this episode what will happen to the vascular tone if we give the patient alpha-1 receptor? Alpha-1 receptor agonist. That's right. Vascular tone will increase because, as we already mentioned, alpha-1 receptor stimulation causes vasoconstriction. Now, how do we make the best use of this property from the pseudoephedrine and phenylephrine? Well, we use them as nasal decongestants. So they are in the nasal sprays that we usually spray in the nostrils when we have the common cold. And when we spray the pseudoephedrine and phenylephrine in the nostrils, they vasoconstrict the vessels in the nasal mucosa. And this will decrease the nasal hyperemia, and this will also decrease the nasal discharge and the nasal mucosal edema. The reason for this is that the nasal discharge during the common cold or during any other infectious condition is actually the modified plasma. What I mean here is that the vessels in the nasal mucosa get vasodilated due to acute inflammation, and then the plasma is going through those vessels from the blood vessel to the nasal mucosa. This is how the nose gets stuffed. So if we constrict those vessels, then we will limit the blood flow to the vessels of the nasal mucosa, and we will diminish the nasal discharge. And the pseudoephedrine and phenylephrine, they also open the obstructed eustachian tubes. Let me remind you that the eustachian tubes are also known as pharyngotympanic tubes because they connect the nasopharynx to the tympanic cavity or the middle ear cavity. And when we have the upper respiratory infection, this discharge, the nasal discharge, and this substance, the fluid, also obstructs the eustachian tubes. And this is why sometimes our ears also feel congested when we have the common cold. So pseudoephedrine and phenylephrine, when applied nasally, can also reach the eustachian tubes, and they can open up those tubes so that our hearing gets better. Now, let's move on to the side effects of these two drugs. One of the most important side effects is the hypertension. And before we analyze the mechanism behind this side effect, let me tell you one thing. We spray the pseudoephedrine or phenylephrine in the nose to minimize the systemic side effects like hypertension. However, nasal mucosa is very rich in capillaries, which means that there is still some systemic absorption of either pseudoephedrine or phenylephrine. And therefore, we can still have the systemic side effects like hypertension. And the mechanism for this side effect should be clear for all of us at this point. We have mentioned for several times during this episode that alpha-1 agonists cause vasoconstriction. And if we induce the generalized vasoconstriction of the peripheral arterioles, this will definitely increase the mean arterial pressure and will cause the hypertension. A very high yield phenomenon associated with nasal decongestants, not only with pseudoephedrine and phenylephrine, but also with, let's say, oxymetazoline, is rhinitis medicamentosa. Rhinitis medicamentosa is the rebound nasal congestion if nasal decongestants are used for more than 4 to 6 days. And the underlying mechanism for this phenomenon is something called tachyphylaxis. Okay, guys, do you remember from the general pharmacology what the tachyphylaxis is? I hope you do, but still, let's explain it. Tachyphylaxis is the rapid desensitization of the receptor towards its ligand. What we mean here is that when we apply nasal decongestants several times per day for a week, those alpha-1 receptors in the nasal mucosa get desensitized. So they get downregulated, and therefore they become unresponsive to further application of the pseudoephedrine and phenylephrine. This means that after several days, even if we spray the nasal decongestant, this will not improve our nasal discharge. It will actually worsen the nasal discharge because the capillaries and the arterioles in the nasal mucosa will stay dilated. And this is also a very, very clinically significant point. We should discourage the patients to use the decongestants for more than a week. And the mechanism is what we explained right now. And the last side effect is that these medications, both pseudoephedrine and phenylephrine, can cause CNS stimulation and anxiety. Oh, let's get back a little bit. So let's forget what I've said, because I need to tell you that it's only pseudoephedrine which has the CNS stimulatory side effect. And there is the mechanism for this as well. Pseudoephedrine is called so because this is an analog of the original substance called ephedrine. And ephedrine normally works by increasing the release of norepinephrine in the CNS. And this property is maintained with the pseudoephedrine as well. So to say it in other words, pseudoephedrine activates alpha 1 receptors and it releases norepinephrine in the CNS. Norepinephrine is an excitatory neurotransmitter, and excessive levels of norepinephrine can definitely cause the CNS stimulation. Okay, this was discussion about the pseudoephedrine and phenylephrine. And let's move on to the medications used for the pulmonary hypertension. Before we start talking about the different classes, let me give you one very important piece of info. These medications are mostly used for the group 1 pulmonary hypertension. According to WHO, there are 5 different groups of pulmonary hypertension depending on the underlying disorder. And these drugs that we're going to discuss right now are used mostly in group 1 pulmonary hypertension, which is also known as pulmonary arterial hypertension. The first class of the medications that we're going to discuss is endothelin receptor antagonists. Let's step back a little bit and review the pathophysiology of endothelin and its effects. Guys, do you remember what the effect of endothelin is? I really hope you're telling me that endothelin is the vasoconstrictor. Endothelin 1, when stimulating its receptor on the vascular smooth muscle cells, causes excessive vasoconstriction. And it's actually thought to be more potent than, for example, angiotensin 2, which is also a vasoconstrictor. Therefore, if we block the endothelin 1 receptor, it means that endothelin 1 can no longer cause the vasoconstriction, and the vessels will stay dilated. In pulmonary hypertension, we have reorganization of the tissue, intimal hypertrophy, and intimal fibrosis, and also the smooth muscle hyperplasia, which causes narrowing of the vessel lumen. This is why we need to dilate the pulmonary vessels in the patients with pulmonary hypertension. The classic drug that belongs to endothelin receptor antagonist is bosentan. The other drug that you should probably know is Umbresenten. Bosentan is severely hepatotoxic, which means that if we prescribe bosentan to the patient, then we should check the liver function tests every now and then. For step 1, we do not need to know how often we should check the liver function tests for bosentan, but still we should know the fact that bosentan is hepatotoxic. Okay, and the classic question that might come up in any of your Q banks or on the actual exam is that the patient has pulmonary hypertension, he or she is started on bosentan, and then the question might ask which of the following should be periodically checked in this patient. And the right answer will be the liver function tests. Okay, the next class of the medications used in pulmonary hypertension is phosphodiesterase 5 inhibitors, also known as Pd5 inhibitors, right? Pd5 is the enzyme that normally breaks down the cGMP. cGMP is one of the second messengers, right? Okay, here's my question to you guys. Do you guys remember what the effect of cGMP is on the vascular tone? Are you saying that cGMP decreases the vascular tone by vasodilation? If you are, that's perfect, because this is the exact mechanism of how cGMP works. And if we want to be a little bit more specific, then we should also mention that cGMP activates protein kinase G, which then phosphorylates and activates dependent, I don't remember the name of the enzyme, myosin light chain phosphatase. Yes, myosin light chain phosphatase, or MLCP, is phosphorylated and activated by the protein kinase G, and then this enzyme will dephosphorylate the myosin in the smooth muscle. By this mechanism, MLCP will block the smooth muscle contraction, and this will result in vasodilation. I'm sorry for stuttering there, because I just had the hard time to remember the exact name of the myosin light chain phosphatase. Okay. Now, what is important about the Pd5 inhibitors? Well, all of these drugs end in the suffix -aphil. So the example drugs are sildenafil, tadalafil, vardenafil, avalafil, evanafil. Almost anything that ends with aphil is the Pd5 inhibitor. And you might have heard about sildenafil from the pharmacology of the other system, right? Sildenafil is also used to treat the erectile dysfunction. And the reason for this is that just like these drugs dilate the pulmonary vessels, they can also dilate the sinuses in the corpora cavernosa of the penis, and therefore they can induce erection in a man. Probably the highest yield fact about the Pd5 inhibitors is what we are going to discuss right now. We should absolutely avoid Pd5 inhibitors with, that's right, nitrates. Now, you'll be even cooler if you can think of the reason why these two drugs are contraindicated together. I hear you. Generally, all the nitrates release the nitric oxide, or NO, which works on the same second messenger system. It works through the cGMP. In other words, nitric oxide causes vasodilation by stimulating the cGMP. If we combine the nitrates and the Pd5 inhibitors, then we will have excessive cGMP in the vascular smooth muscle, and this will cause very severe vasodilation. And this can finally result in very, very severe hypotension. So please remember this association between Pd5 inhibitors and the nitrates. The last class of the medications used in the pulmonary hypertension that we are going to discuss now is prostacycline analogs. Before we move on, let's take a step back and let me ask you a question. Could you please remind me the mechanism of action of prostacyclin? That's right. Prostacyclin is also known as PGI2, and prostacyclin is the natural vasodilator, and it also inhibits the platelet aggregation. So we came up with the synthetic analogs of the prostacyclin, which have the same vasodilatory property as the natural prostacyclin. And they will dilate both pulmonary and also systemic arterioles as well. Now, the examples of the prostacycline analogs are epoprostenol, iloprost, treprostinil. In general, any drug that has prost in its name is the analog of some kind of prostaglandin. And you can actually hear the prost in all of these three drugs that we discussed right now. Epoprostenol, iloprost, treprostinil, right? Now, the side effects for prostacycline analogs include the flushing, facial flushing. Flushing occurs due to vasodilation of the skin vessels. Another side effect is the jaw pain. There is not a specific mechanism behind these side effects, but if you remember this, it'll be really, really good. Okay, now let's move on to the asthma drugs. Before we talk about the individual drugs, we need to remember what causes the bronchoconstriction in asthma. Bronchoconstriction in asthma is caused by two processes. First, this is inflammation, which results in excessive mucus production and the cellular infiltration in the bronchial walls, which then narrows down the bronchial lumen. And the second mechanism of bronchoconstriction in asthma is an excessive parasympathetic tone. Let me remind you that we have M3 muscarinic receptors in the bronchi, activation of which causes bronchoconstriction, and at the same time we have beta-2 sympathetic receptors, activation of which causes bronchodilation. And the pharmacotherapy of asthma revolves around these two concepts, the inflammation and excessive parasympathetic tone. We need to decrease inflammation, mostly by corticosteroids, and we also need to either decrease the parasympathetic tone by blocking the muscarinic receptors or increase the sympathetic tone by stimulating the beta-2 receptors. Right. The first drug that we are going to talk about is beta-2 agonist. Beta-2 agonists are inhaled medications. Well, they can be in other formulations as well, for example, oral, but still inhaled formulation is most commonly used. And we have short-acting beta-2 agonists and the long-acting beta-2 agonists. And the difference between them is really about the duration of action. Short-acting beta-2 agonist is albuterol, and it relieves bronchoconstriction by stimulating the beta-2 receptors, which causes bronchodilation. Albuterol is the rescue inhaler. It is used for the acute exacerbation of asthma, and it's also used whenever the patient feels that the asthma attack is coming. Salmeterol and formoterol are the long-acting beta-2 agonists, and they are considered to be the maintenance therapy. Not only they have the long duration of action, but at the same time, they start working a little later than albuterol. In other words, they will not relieve the shortness of breath as soon as albuterol. This is why albuterol is the rescue inhaler, and this is the first line that we should give to the patient with acute asthma exacerbation. And the general point to remember about any beta-2 agonist is that they can cause tremor and arrhythmias. The idea here is that although they are inhaled and the systemic absorption is minimal, still there is some amount of the beta-2 agonists that are absorbed in the blood from the alveoli. And then by stimulating the beta-2 receptors in the body, they increase the sympathetic tone. When we increase the sympathetic tone, we can get the tremor and we can also get the arrhythmias too. Okay, now let's move on to the muscarinic antagonists. We have two drugs here. We have ipratropium and tiotropium. Just like we have the short and long-acting beta-2 agonists, the same way we have short and long-acting muscarinic antagonists. Ipratropium is the short-acting anti-muscarinic medication, while tiotropium is the long-acting one. And as we already understand, they block the M3 muscarinic receptor, and therefore they prevent the further bronchoconstriction. Now, both of these medications, beta-2 agonists and the muscarinic antagonists, can also be used in the COPD patients. So right now, we are discussing the asthma therapy and the COPD pharmacotherapy as well, because there is a significant overlap between the medications used in these two conditions. Another class that we are going to use both in asthma and COPD is inhaled corticosteroids. This class includes the drugs like fluticasone and budesonide. And as we know, steroids are anti-inflammatory medications. They have various mechanisms by which they decrease the inflammation. They directly suppress the T cells, and they indirectly suppress the B cells. And by suppressing almost all lymphocytes, they decrease the synthesis of pro-inflammatory cytokines. They also inactivate the transcription factor, which is called, do you remember what it's called? It's called NF-kappa B. And NF-kappa B is the transcription factor responsible for the synthesis of pro-inflammatory cytokines. So by blocking NF-kappa B, corticosteroids decrease the concentration of the pro-inflammatory cytokines like tumor necrosis factor alpha, IL-1, IL-6, and etc. Inhaled corticosteroids are also considered to be the maintenance therapy for both asthma and COPD. If the patient has asthma or COPD exacerbation, we will likely go with the systemic corticosteroids like oral or IV corticosteroids, because exacerbation is the acute life-threatening condition and we need to deliver the drug as soon as we can. And for this, we should use the systemic administration. A very high-yield fact that we should mention about the inhaled corticosteroids is that we should encourage the patient to rinse the mouth or use the spacer with the steroids. Now, can you please remind me the reason for why the patient should rinse the mouth after inhaling the corticosteroids? Are you saying that inhaled corticosteroids can cause the oral thrush? If you are totally right. And the reason why inhaled steroids can cause the candida thrush is that they decrease the local synthesis of interleukin-2 in the oral mucosa. And let's remind ourselves that interleukin-2 stimulates all the different types of T cells. T cells on their own are necessary to fight off the fungal infections in the tissues. So if we have low interleukin-2, then we have decreased concentration of the T cells locally in the oral mucosa, and therefore we have the higher chance of the candidal overgrowth and the oral thrush. Okay, the next class of drugs is anti-leukotrienes. I think we also need to step back here and briefly recall the normal function of the leukotrienes. Leukotrienes, just like prostaglandins, are arachidonic acid derivatives, and different leukotrienes have different function. The leukotrienes that we care most in this particular discussion are leukotrienes C4, D4, and E4. The general mechanism of all of these three leukotrienes is smooth muscle contraction. They contract the vascular smooth muscle, which causes vasoconstriction. They contract the bronchial smooth muscle, causing bronchoconstriction. And finally, they also cause increased vascular permeability by contracting the pericytes between the basement membrane and the endothelial cells. Okay, now we said that LTC4, D4, and E4 cause bronchoconstriction. Therefore, they can contribute to shortness of breath in asthma. And we need to either block the leukotriene receptors or we need to block the leukotriene production. We have two medications which block cis-LT1 receptor, which is the leukotriene D4 receptor. Could you please remind me those two medications? That's right, I can hear you. This is montelukast and zafirlukast. They are very effective, especially for exercise-induced asthma and aspirin-induced asthma, which is now called aspirin-exacerbated respiratory disease. Although we said that anti-leukotrienes are effective for the exercise-induced asthma, I would like you to remember that the first-line anti-asthmatic medication for exercise-induced asthma is still albuterol. Okay, now let's talk a little about the aspirin-exacerbated respiratory disease and the clinical significance of blocking the leukotriene pathway in this condition. Some people, when taking aspirin, develop asthma-like symptoms, shortness of breath, wheezing, and etc., prolonged expiration. They commonly have the nasal polyps as well. The idea here is that aspirin blocks both cyclooxygenase 1 and cyclooxygenase 2. Guys, can you remind me what these enzymes yield? I mean, what the product is for these enzymes? I hope you're telling me that cyclooxygenases make prostaglandins. Now, if we block both cyclooxygenases, then all of that arachidonic acid that was supposed to go into the prostaglandin pathway will be shunted towards the leukotriene pathway. And we will get excessive leukotriene C4, D4, and E4 that will cause bronchoconstriction. This is how we get asthma-like symptoms in certain patients who take the aspirin. Now you can imagine that if we use leukotriene receptor antagonists in these patients, then even though they have high amount of those leukotrienes, they cannot activate their receptors if we give montelukast or zafirlukast. The last anti-leukotriene medication is called xyluton. But xyluton is different from montelukast and zafirlukast. Guys, can you tell me the difference between xyluton and the other two drugs that we already discussed? That's absolutely true. Xyluton blocks the production of the leukotrienes rather than their action on the receptor. To be more specific, xyluton inhibits the enzyme called 5-lipoxygenase. 5-lipoxygenase is the rate-limiting enzyme for the leukotriene pathway. It converts the arachidonic acid into the parent leukotriene, which is called 5-HPETE. Well, it's called 5-hydroperoxyicosahexatetraenoic acid, but I have good news for you. We don't have to know the full name of this product. Okay, it's enough to remember that 5-lipoxygenase converts arachidonic acid to the parent leukotriene molecule. So if we give xylitol, it means that we will decrease the production of all the different types of leukotrienes. One setback of xylitol is that it is very, very hepatotoxic, and therefore periodically measuring the liver function tests in the patient on xylitol is not a bad idea. Now we will talk about the anti-IgE monoclonal therapy. And the specific drug that I have in my mind is omalizumab. Omalizumab binds to the free serum IgE, so the IgE molecule that floats freely in the plasma, and it blocks the binding of IgE molecule to the IgE receptor, which is also known as Fc epsilon receptor 1. This is the IgE receptor on the different types of cells, for example, the mast cells, the basophils, the eosinophils. If we block the binding of IgE on the mast cells, then we will prevent degranulation of the mast cells in the first place. And can you please tell me which preformed mediator is released instantly after the mast cell degranulation? Yeah, say it louder. That's histamine. So by giving omalizumab, we block the histamine release from the mast cells and the basophils, and mostly from these two cells. Omalizumab is not used as the first-line medication in asthma. Omalizumab is considered if the asthmatic patient has elevated IgE levels and she or he is resistant to the inhaled corticosteroids and the beta-2 agonists. Okay, now the next class of medications is methylxanthines. Guys, could you please remind me the example drugs from the methylxanthine group? Are you saying theophylline? That's right, theophylline is one of the methylxanthines. In fact, theophylline is the most commonly used methylxanthine in the pharmacology. The other medication, not the medications, but the other methylxanthines are caffeine and theobromine. Now, theophylline and all the other methylxanthines are non-specific phosphodiesterase inhibitors. In other words, they block all the different isoforms of the phosphodiesterases. And this is how they increase the CAMP levels in the bronchial smooth muscle. And when CAMP level increases, this causes bronchodilation. If we want to go into details, let's say this. CAMP activates protein kinase A, and then protein kinase A phosphorylates and inactivates myosin light chain kinase. If we inactivate MLCK, or myosin light chain kinase, it can no longer phosphorylate the myosin, and therefore smooth muscle contraction won't happen anymore. I know that was a big mechanism, and I know it's a little bit hard to imagine. However, it's good if we remember why methylxanthines cause bronchodilation. Another important thing about theophylline and any methylxanthine is that they are adenosine receptor antagonists. Adenosine has the GQ-coupled receptor in the bronchi, specifically on the bronchial smooth muscle, which means that if we give adenosine to the patient, then the patient will experience bronchoconstriction. Now, if we give theophylline to the patient, then theophylline will block the adenosine receptors, including those in the bronchial smooth muscle, and this will cause bronchodilation. So this is the second mechanism of how theophylline causes bronchodilation. Theophylline has a very, very narrow therapeutic index. In other words, the range of the dosage within which theophylline is both effective and safe is very narrow. And we need to monitor the theophylline levels in the plasma very carefully, because we can induce theophylline toxicity very easily. Now, the reason for this is that theophylline is the substrate of cytochrome P450. And as we know from the general pharmacology, there are many, many inhibitors and inducers of the P450 system. Now, we are not going to list all of those inducers and inhibitors here because that's beyond the scope of our discussion, but I'd like you to tell me what will happen to the theophylline plasma concentration if we co-administer the P450 inhibitor. I hope you're telling me that in this case, theophylline plasma concentration will increase and we might get theophylline toxicity. Theophylline toxicity usually presents with cardiotoxicity and the neurotoxicity. In other words, the patient might have serious life-threatening arrhythmias and also seizures. Now, what will happen if we give theophylline together with the P450 inducer? Are you saying that P450 inducer will decrease the efficacy of theophylline? If you are, that's totally true. In that case, theophylline will not help as much as it should. Okay, now another class that's important to mention is chromones. And the example medications here are cromolyn and nedocromil. They have very, very simple mechanism of action, and it's very understandable and imaginable. Chromones block the mast cell degranulation. So they totally block the release of all the mediators from mast cells, including that of histamine. And this is how they can prevent the acute asthma symptoms. Regardless, let me tell you that chromones are very, very rarely used because these medications don't have the super high efficacy, and at the same time, their side effects are kind of annoying for the patient. They cause the irritation of the upper airways. They might induce the sore throat or nagging cough. This is why it's not the first line agent and it's not the patient's favorite agent either. Okay, and so the last class of medications that we need to discuss here is the anti-interleukin 5 therapy. We have here 3 monoclonal antibodies which block the action of the interleukin 5. Let me remind you from the immunology that interleukin 5 stimulates B cells, class switches to IgA production, but most importantly for our current discussion, stimulates eosinophils. And as we know, eosinophils are very important in the allergic reactions, including asthma. If the patient has eosinophilic asthma, then we can definitely give anti-interleukin 5 therapy. But again, so they are never the first line, because first, they are very expensive, and second, we have the other medications that we need to try first. Mepolizumab and reslizumab block the interleukin 5 itself. In contrast, benralizumab blocks the interleukin 5 receptor alpha. And these medications are newly added in the first aid and the USMLE world, so it means that some people have had the questions about them on their exam. This is why I would like you to remember these. Okay, and the final medication that I just want to mention is roflumilast. Do you guys know what medication roflumilast is? That's right, it's the phosphodiesterase 4 inhibitor, which is used only in COPD, not in asthma. And PDE4, blockage of PDE4, also induces bronchodilation. Okay, we have come to an end of our today's discussion, and let's summarize everything that we have discussed. In this episode, we have discussed the respiratory pharmacology for the USMLE Step 1. We started this episode by talking about the first and second generation antihistamines. Then we continued talking about the dextromethorphan, pseudoephedrine, and phenlephrine. We also talked extensively about the pulmonary hypertension drugs, namely endothelin receptor antagonists, Pd5 inhibitors, and finally the prostacyclin analogs. And in the end, we discussed several classes of medications which are used in asthma and COPD. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, USMLers, and see you on the next episode.